So AOC and Wednesday classes, we all thrive to achieve this aim to enhance each other learning and to keep ourselves updated by helping each other and discussing cases, literature reviews, and other seminars and webinars. So today is the day for case discussion, AOC and interesting case discussion. We will have two cases today. The first case will be presented by Dr. Sujata, who is Senior Resident in Department of Pediatrics at AIIMS Jodhpur. And the same team will be moderating and chairing the session. Dr. Lakesh Saini, who is a good friend, and he's assistant professor in Department of Pediatrics at in AIIMS Jodhpur. And the session will be chaired by Dr. Sarvesh Tiwari, who is Associate Professor in the Department of Radiology at AIIMS. He has special interest in pediatric neurology, and he's also into intervention radiology. So they will be presenting a drug-induced encephalopathy case. And second case will be by AIIMS Delhi team. Dr. Kaushik Raghunath will be presenting the case, who is DM Senior Resident Pediatric Neurology at AIIMS. And it will be moderated by Dr. Biswarup Chakravarti, who is additional professor at AIIMS Delhi. And Dr. Shefali needs no introduction, who will be chairing the session. She is HOD and professor and Chief of Child Neurology Division at Department of Pediatric Neurology at AIIMS. So I will hand over now to Dr. Lakesh, who will moderate the first case. Kindly take over, Dr. Lakesh Sen.
Good evening, everyone. So I straight away invite my senior resident, Dr. Sujata, for presenting the first case. She has done her MD from AIIMS Jodhpur only, and now she is doing senior residency in pediatrics. And she has a special interest in pediatric neurology. She is an aspirant. So Sujata, you can start.
Thank you. So, should I start sharing my screen, sir?
Yes. Yes.
So good evening to one and all present here. We will be seeing an interesting case came to our pediatric emergency. So outline, we will see about the case in detail, followed by a summary of the similar cases we had in the consecutive months and a short discussion regarding this. So coming to the case, baby T, she is a 4-year-old girl presented to us. She was hailing from AIIMS Jodhpur. Informants were father and mother, and they were reliable. And she presented to our pediatric emergency in one midnight with history of low-grade fever for 2 days, cough coryza for 2 days, and unresponsiveness for 2 hours. So she was apparently well 2 days back, and initially, to begin with, she had low-grade undocumented fever, which was intermittent in nature. There was no chills, rigors associated, and it was getting relieved by paracetamol. And she was active during the interfebrile period also. And she had cough and coryza also for 2 days. And there was no significant breathing difficulty or post-acute vomiting. So for these complaints, she was taken to a nearby hospital where few medications for cough and fever were prescribed. Around 8 p.m., mother gave medications and made the child sleep. Around 11 p.m. when she tried to wake up the child, she found that the child was not responding even for painful stimulus, and she was taken to our emergency with these complaints. So these were the medications shown by the parents at presentation. Then there were no history of convulsions on the way to hospital or at home, and there was no frothing from mouth or tongue bite suggestive of convulsion at any point. There was no history suggestive of any cranial nerve involvement like loss of vision or difficulty in chewing, swallowing prior to the onset of symptoms. And there was no history of weakness of any limb or abnormal twisting postures also. So there were no history suggesting autonomic disturbances like urinary retention or incontinence or bowel incontinence. No history of jerky pendular eye movements. There was no other neurological history except for the unconsciousness noticed for 2 hours. There was no history of headache, projectile vomiting, neck pain, or excessive irritability. No history of ear discharge, yellowish discoloration of eyes or skin, or any bleeding manifestations anywhere. There was no prior loose stools, abdominal pain or distension, or any recent vaccination. No history of any bites like dog bite or snake encounter or any high risk environment. They are living in a city only where there is no exposure for venomous animals or insects, and there was no history of any TB contact, loss of weight, or inadequate weight gain also. So past history wise, there was nothing contributory in the child. Perinatally, child had an uneven full course with smooth transition. Development wise, she was normal for age and she was completely immunized for age. Nutrition wise, also she had a mild calorie deficit of 18% and protein deficit of 8%. Otherwise, thriving well. Family history, she was born out of a non-consanguineous marriage. She had an younger male sibling who was 2 years old. Around the same time, he also had fever, cough, coryza during like when the child had the symptoms, like the index child had the symptoms, and he was also given the same medications in a relatively lower dose. Like 5 ml of the syrup was given to the elder child, and he was given 2.5 ml of the syrup, which was shown previously. So after that, he was also found to be unresponsive at the same type period of time, and both of them were taken to our emergency. Unfortunately, the child, the younger sibling who was the male, was unconscious at presentation, was found to have no signs of life. We tried to resuscitate, and despite our best efforts, we couldn't revive the child. Coming to the short database of the history, like we had a 4-year-old girl with normal growth and development for age and compliance of fever, cough, coryza for 2 days and acute onset unresponsiveness for 2 hours. The unresponsiveness was noted after the ingestion of cough medication, which was given by the parent in the dose prescribed. And there was history of similar presentation in her 2-year-old younger brother also simultaneously. So at this point of time, we kept the differential diagnosis of any infectious causes like viral encephalitis or meningoencephalitis. Scrub was one possibility. Acute necrotizing encephalopathy was another possibility, and ADAM. And could be a poisonous or drug overdose like organophosphorus compounds, opioids, or sedative hypnotics. And we low down, we kept the like other causes like PCA stroke and AVM aneurysmal bleeds also, since there was acute onset encephalopathy. And at arrival, child airway was like airway and appearance, there was decreased responsiveness. Within 5 minutes of arrival only, child had one episode of tonic posturing of all 4 limbs, which lasted for almost 2 minutes. And there was increased respiratory rate, and color was normal. So initial child was triaged as unstable, life-threatening. And the primary assessment proceeded, like airway was clear, breathing was tachypnic, child was tachypnic at presentation with a saturation of 70% in room air, and bilateral air entry was equal, even though heart rate was 188 per minute, tachycardia, pulses were well palpable, and CFT was 2 seconds with warm peripheries, and child was febrile also 102 Fahrenheit. BP was slightly on the higher side, like hypertensive recording 131/67. GCS was E1, V1, and M1. Pupils were bilaterally constricted. They were not reacting to light. And RBS at presentation was 42 milligram per deciliter. There were no bite or fang marks or external injuries on exposure. So airway was secured with cupped endotracheal tube in view of encephalopathy. And Deton bolus was given initially because of hypoglycemia, and as a hypertonic saline bolus was also given in view of hypertension and encephalopathy, keeping raised ICT in mind. And since there were pinpoint pupils, opioid ingestion was kept as a possibility, and a trial of naloxone was given. Since there was minimal reaction of pupil, 2 boluses were consequently given, and the child was started on infusion. Empirically, child was started on ceftriaxone and acyclovir to cover common organisms. On general examination, child was comatose. Other than that, there was no remarkable findings like rash or injuries or fang marks. Anthropometry wise, child was normal for age, like weight, height, head circumference, everything was normal. System examination, in CNS, higher mental functions, child was comatose. Cranial nerve examination revealed bilateral pinpoint pupils, which was not reacting to light initially. After giving naloxone, there was minimal reaction and response. Other than that, no remarkable cranial nerve abnormalities could be found. Motor examination revealed a decreased tone in all 4 limbs with brisk reflexes. And other CNS examination, we couldn't find anything at the time of presentation. And other system examination like cardiovascular, respiratory, and per abdomen were essentially normal. So, case summary, 4-year-old girl with appropriate growth and development presented with complaints of fever, cough, coryza for 2 days and acute onset unresponsiveness for 2 hours with a history of simultaneous similar presentation in her 2-year-old younger brother. On examination, child was comatose, was found to be in respiratory failure with pinpoint non-rejecting pupils and hypoglycemia and 1 episode of seizures in ER. CNS examination revealed reduced tone with brisk DTRs and bilateral extensor platter, and other systems were essentially normal. So the initial differentials we kept were viral encephalitis and meningoencephalitis, since there were history of prodroma fever in the index child and the sibling also, and encephalopathy followed by seizures. Points again, there were no rash, but which could be seen in herpes encephalitis. Scrub, we couldn't find any eschar. The other positive findings were fever, cough, coryza followed by acute onset encephalopathy. Acute necrotizing encephalitis could be a possibility where there is a deep encephalopathy followed by a prodrome of viral infection, and ADAM we kept lower down. So coming to the poisoning of the drug overdose group, opioid was the first differential we kept, and since we had a history of dextromethorphan ingestion also, and points in favor were acute onset encephalopathy with pinpoint pupils, hypoglycemia, respiratory failure, and similar history in sibling who also had the drug. And points again, there were no bradycardia or bradypnea, instead the child had tachypnea, and there was hyperthermia presentation. Usually opioid poisoning presents with normal temperature. OP poisoning could be the another similar mimic, but there were more points which goes against OP poisoning. There were no increased secretions, diaphoresis, and no diarrhea or other systemic involvement which could be seen in OP poisoning. And sedative hypnotic overdose, there was pinpoint pupils and encephalopathy, but there was no history or any access to those kind of drugs. And vascular causes still were kept even lower down, because other than pinpoint pupils and encephalopathy, there were no other supportive findings like headache or focal neurological deficit or any family history or similar history in sibling. And coming to the initial investigations, we had blood counts were normal with a mildly elevated SGOT-PT, and KFT was also normal. CRP was 1.99 and PCT 12.3. Scrub IgM was negative, dengue serology was negative, and rapid malarial testing and smear for malarial parasites were also negative. COVID-19 IgG antibodies were positive by ELISA, and blood culture was sterile. We did a CSF analysis where cytology revealed RBC count of 5 and WBC of 2. It was clear in appearance while performing it, and protein sugars were also in the normal range. There was no bacteria seen on gram staining or FB staining, and eventually the culture was also sterile. So we had a neuroimaging in ER. NCT showed no intracranial bleeding. Eventually, we got the MRI brain done on the next day, which revealed symmetrical foci of restriction seen in bilateral centrum semi-ovale, shown by the white arrows in figures A and B, and frontal white matter shown by the dashed arrows. We can see the hyperintensities in the cerebellar hemispheres also, and the contrast, post-contrast image showed normal contrast enhancement without any abnormalities. So coming to the management of the child, initially we corrected hypoglycemia, raised ICT measures were started, osmotherapy with hypertonic saline was given. Naloxone boluses followed by infusion was provided for 2 days, since there was a initial response, pupillary response, and respiratory improvement. Methylprednisolone pulses for 5 days was given, followed by oral steroids after ruling out sepsis and meningitis. Empirical antibiotics we continued till blood and CSF cultures were sterile, and the sensorium improved gradually at discharge. The child was conscious, was recognizing parents. There was no residual cranial or deficit, and he had anti-gravity movements and was able to sit up and almost stand with support. So in the same time period, we had similar cases. All the patients had presented with respiratory depression, few had hypoglycemia, few had coma, a few had pinpoint pupils, and one notable thing which we could find in every case was bilateral cerebralitis. And whoever had cerebellar edema, we treated with methylprednisolone and we could find that there was drastic improvement in the sensorium, and they become eventually normal also. So 4 cases we had. The first case which was shown, patient 1, was the sibling of the index case which I'm presenting. So he was presented in cardiopulmonary arrest in our ER, and we couldn't revive the child. The other 3 children, whoever had pinpoint pupils, we gave a trial of naloxone, followed by, if we don't find any focus of infection and if there is no cerebralitis, we treated with methylprednisolone pulse therapy followed by oral steroids, and there was significant improvement in the sensorium, and we could extubate the children and discharge them. So since there was this striking finding of bilateral cerebellar edema with supratentorial enhancement, we did a literature review, and we found one entity called pediatric opioid use associated neurotoxicity with cerebellar edema. So the final diagnosis of the index case was pediatric opioid use associated neurotoxicity with cerebellar edema, and the funding agent in this case was dextromethorphan in antitussive medication. So when to suspect Pound syndrome in an unresponsive child with a viral prodrome who had a circumstantial evidence of ingestion of any opioid containing compound, any infant or child with acute onset altered mental status, any adolescent presenting with abrupt change in behavior with hallucinations or gait abnormalities, and history of ingestion like of the over-counter medications. So the one thing which should be noted in the pharmacology and metabolism is the peak plasma concentration of the drug, which is attained between 2.5 to 3 hours, which was found eventually in all the cases that they started having symptoms around 3 to 4 hours of ingestion of the drug. Coming to the mechanism of action of dextromethorphan, it acts on adrenergic neurotransmitters and block the reuptake of adrenaline, causing tachycardia, hypertension, mydriasis, and diaphoresis. NMDA blockade causes hallucinations, euphoria, dissociation, agitation, and coma. And the serotonin syndrome, which can be precipitated, can present with seizures, muscle rigidity, and rhabdomyolysis. So it's a toxic encephalopathy in children with opioid overdose. There is prominent cerebellar edema with variable supratentorial involvement. There will be distinct, this is the distinct pattern seen in opioid toxicity, more reported in adults rather than pediatric population. The clinical features usually are respiratory depression, decreased level of consciousness, mutism, and ataxia. Clinico-radiological monitoring is required in these cases since they are prone for herniation, compression, and hydrocephalus secondary to edema, and may require extraventricular drains or posterior cranial fossa decompression and or cerebellectomy. So literature on the similar cases in adults had presentation with bilateral symmetrical centrum semioval involvement, which is called the chasing the dragon leukoencephalopathy post heroin use. So we couldn't find any literature after use of dextromethorphan in children causing cerebellar edema or encephalopathy. So, but there are circumstantial case reports which support that there is some association between opioid overuse and this kind of clinical presentation. And the proposed mechanism of neurotoxicity with opioids is that it could be due to direct neurotoxic effect leading to cytotoxic edema, or the opioid-induced toxicity may lead to oligodendrocyte toxicity and demyelination and increased blood barrier permeability and edema. So, and neuronal damage may be through mitochondrial insult and the apoptotic upregulation. So the exact mechanism is still under question. The consistent imaging findings which have been reported in the previous case reports and case series were CT scan with bilateral cerebellar edema, which appears hypodense cerebellum on CT, and MRI showing cerebellar edema symmetrical with variable supratentorial white matter lesions with hyperintensities on T2 and diffusion restriction in some areas. There could be features of mass effect, hydrocephalus, or tonsillar herniation also. So coming to the take-home messages, like treatment history in a child presenting with acute onset encephalopathy is important, because despite significant structural changes which are seen in these neuroimaging, the clinical outcome once we treat this children was very remarkable. They improve very drastically, and these children may require series of diversion procedures like EVDs or shunts, and they are life-saving. Early suspicion and diagnosis and appropriate management will do wonders in these cases. So although opioid overdose remains a significant public health concern, data on how it affects young children are lacking. So we need to create more evidence on this part. Recognition of causes can guide clinicians to provide a diagnosis for patients and families, and so that we can prognosticate them too. So there are few yet to be answered questions. What is the exact mechanism of neurotoxicity by dextromethorphan or any opioid compound per se? Why do only a few patients manifest neurotoxicity? Why not everyone who ingests dextromethorphan don't have this kind of dramatic presentation? Are they genetically predisposed to this kind of presentation? This is yet to be answered. Is there any role of viral infection in the pathogenesis of Pound syndrome in children? That part is also a query. And are there any specific viral triggers like COVID-19? Like in the index case I presented, we could find COVID serology was positive for IgG antibodies, and we could find a serial of cases with similar presentation also, and few of them turned out to be COVID-19 antibody positive too. So is there any specific virus which triggers this kind of presentation? That also. And finally, like we had similar events in Delhi reported in 2021, where the government took action on 3 doctors for prescribing dextromethorphan, and 3 children expired in Kalavati Saran Hospital. So like the doctors are really at fault, or the medicine is at fault? That raises a question, and this is a thought-provoking presentation. So these are my references, and thank you.
Yeah. So very good presentation, Dr. Sujata. Definitely an interesting and intriguing cases. Dr. Lokesh, Dr. Sarvesh, can you just discuss the neuroradiology findings in the differential diagnosis?
Yes, sir.
Can you present? Can you project your MRI findings again?
Yes, sir.
So it's very interesting. So actually, we had published a case of cerebellar involvement in COVID-19 infection. And we were interacting, me and Dr. Lokesh, and he told that he has seen similar cases previously also. And that that maybe this drug is associated, dextromethorphan. And then we had the series of 4 patients which came, and then we looked into literature. So can we see the images? Yes. Okay, we are not seeing the image. Hello.
Sujata, image is not visible.
I think Dr.
Can
Sujata's
you
screen
cancel
has
or do?
frozen.
Okay.
No. Can I share my screen? Even I can show images if possible.
If Dr. Sujata can unshare her, stop sharing her screen.
Sir, her screen has frozen. I think I don't know whether she is able to hear us.
Yes.
You can call, I think.
Yes, sir.
Is my screen visible now?
Yes, it is.
Yes.
Yeah. So I think I'll just show my screen. Let me, if I can partially annotate it now. Trying to hide the patient identity. Okay. So these are the flare images. Okay. And if you see, we see symmetrical signal changes. This is the cerebellar white matter, and this is the cerebellar cortex. So we kind of see symmetrical involvement of bilateral cerebellar hemisphere involving the cortical areas rather than the white matter area. As we move up, we don't see much on the flare images. Now, but when we see the diffusion images, kind of this thing lights up. So you see this diffusion restriction. These are all subcortical white matter involvement, and they are in the frontal, in the parietal subcortical white matter. As we go down, this is the frontal subcortical white matter, and you see this caudate head involvement here as well. So similar kind of imaging is described in oxycodone poisoning and methadone poisoning. Because these changes are so symmetric, we should consider metabolic insult as differential from radiological point of view. And first case when I saw, I mean, it was one case was before this also, I thought this is a kind of viral infection which is involving white matter. But in second case, third case, we went into literature and we found multiple case reports, oxycodone poisoning separately, morphine poisoning separately, methadone poisoning, all opioid induced. And now they have grouped all this under Pounce syndrome, which are neurotoxicity secondary to opioid ingestion. So these were the finding in my case. Mostly in a higher dose ingestion, you can see gross cerebellar edema, which will compress the fourth ventricle with hydrocephalus. This is what we are seeing in this kind of cases.
Okay, thank you. I think Dr. Lokesh, can you
Yes,
take up
sir.
the questions, because most of people are interested about the dose which was invested, and is there any dose relation with the toxicity?
So the sir, dose was very minimal. For the index child, only 5 ml was taken, and for the younger child, only 2.5 ml. So dose has no relation to the symptoms. These are just idiosyncratic reactions to the dose, or maybe some viral trigger is mutually making vulnerable these kids, or maybe some genetic predisposition as was discussed, because two are siblings and both have manifested, both have taken only minimal doses of dextromethorphan. And other kids also which were coming to us, they have not taken any toxic doses, just one dose, and they have manifested in acute encephalopathy after 2 or 3 hours. So it is definitely not related to dose. These are just the doses which is normally prescribed in any kind of normal URI cuff by practitioners.
So, Dr. Kavita is asking, were the images finding different in those who died versus those who survived?
So, sir, with the child who died, we did not image because the child was broad dead. Other children all have similar findings and almost similar findings. All had some cerebral edema. Previously, we remember 2 or 3 kids when we have not suspected this entity at our center only. It was reported by Dr. Sarvesh last year in pediatric neurology. There, where they have done the treating team has done CSF diversion procedure also. But at that time, we were not aware of this entity. So we were seeing this type of cases, but we were missing them. And we once we came to know that this entity shows brisk response to steroids. So like for all 4 kids, remaining 4 kids went back absolutely normal, and they are absolutely normal till now in follow-up. No residual signs, symptoms, nothing. So I recognizing this entity at the onset is very rewarding.
Okay. So yes, Dr. Bishwar was saying that relation to drug metabolism and enzyme polymorphism may be worth investigating. So genetics also may be done.
Yes, sir.
Dr. Kavita is saying that in literature is this OT mentioned whether severe cerebral edema is associated with death due to medullary compression, or in literature review, what was the cause of death? Mostly
yes, sir. It is the herniation which causes it. Is the medullary compression and herniation, eventual herniation. Yes, sir.
So it is steroid responsive, so most likely some cytokine related, maybe.
Yes, sir.
Like CRS, which we are seeing, cytokine mediated encephalopathy.
So edema, cytokine related edema, which is the main culprit here, sir.
So Dr. Umesh has commented that interestingly, another post-viral condition like LERD with diffusion restriction, and suggested the treatment is dextromethorphan. Yes, we had a case today and we started him on dextromethorphan, and I am really scared now. So, and dextromethorphan also cause cerebral changes. So do you think any correlation with LERD, or I don't know?
No, sir.
Definitely the mechanism would be different, worth investigate. So I think thank you the speakers, Dr. Sujata and Dr. Lokesh, Dr. Sarvesh, for a wonderful case and discussion. And now I invite Dr. Vishwarup to take over as to the second case, which will be presented by Dr. Kaushik. Vishwarup, please.
Thank you, Gurpreet sir. So the next case, it will be presented by Dr. Kaushik Raghunath, who is doing DM Pediatric Neurology Senior Residency with us. So this was an interesting case because it presented as an AES, but by the time the child came to us, the child was already 1 month into the illness. And so let us, without any further delay, we'll move on to the case presentation. Yeah, over to you, Dr. Kaushik.
Good evening, sir. Good evening, everyone. I'm Dr. Kaushik from the Department of Child Neurology Division, AIMS, New Delhi. We'll be seeing a case today of an infant who presented with acute encephalitis, an uncommon treatable disorder, or is there more to it? So this was a child who presented at 11 months of age with complaints of fever of 1 month duration with persistent irritability, along with recurrent episodes of seizures and altered sensorium of 1 month. Right from 4 days of illness, the child started having seizures in the form of initially left focal seizures. Thereafter, it was status, and thereafter it evolved to generalized seizures. And it was unresponsive to initial medications, antibiotics, and anti-seizure medications. Over a week, the disease evolved to the following symptoms, like there was positive movements on left half of the body with difficulty in feeding and swallowing. There was also intermittent, bizarre, twisting, posturing of the limbs in the trunk. And almost I can say that with the history, the symptoms had progressed to a change of minimally conscious state within a week. So over the next 2 weeks, the child was shifted to 2 different hospitals. Antibiotics, drugs were upgraded. There was no response to anti-seizure medications as well. And by almost 30 days of illness, the child presented to AIMS. So this was at the time of the presentation. As you can see, there was a child infant with tonic deviation, conjugate deviation of eyes to the right side, and bilateral tonic-clonic jerks were there at the point of presentation. And also the child interestingly had dystonic posturing, as you can see, involving the right hand, right upper limb, and the twisting postures involving the neck, and also conjugate deviation of eyes to the right side. So there were not many dysmorphisms or neurocutaneous markers adding clue to our diagnosis. The child was persistently irritable at the point of presentation, was making very minimal interaction with the mother. The cranial nerves were normal. Fundus showed no papilledema, neither optic atrophy. On motor system examination, the bulk was normal. There was hypotonia involving the left half of the body, hyperreflexia, and there was asymmetric quadriparesis. Left was more involved than the right. Bilateral extensor plantar response. There was intermittent axial and appendicular dystonia, and the child also had positive meningeal signs. So what we have with us is an infant who presented with prolonged fever, with recurrent seizures, altered sensorium that has rapidly worsened, dystonia, asymmetric quadriparesis with positive meningeal signs. So what is involved is the cerebral cortex, the corticospinal tracts, the subcortical gray matter involvement, basal ganglia predominantly, and also the meningeal involvement has been seen. So we made a syndromic diagnosis of acute encephalitis syndrome and proceeded with the discussion of the etiologies. So as the commonest etiology for any acute encephalitis syndrome presenting with fever and altered encephalopathy will be infective. So we thought in terms of a viral, atypical, or a partially treated bacterial, or a tubercular etiology. The second possibility kept was any CNS inflammatory disorder, autoimmune encephalitis, or a demyelination. In this case, it would be Adam sounds more appropriate. And metabolic possibility was also kept in view of sudden decompensation. Organic acidemias or mitochondrial is highly probable. In this particular child, we have kept metabolic below CNS inflammatory autoimmune etiology because the child was premorbidly normal till the point of presentation. So with these differentials, we said to go for investigations. So we did have some investigations in our thing prior to the presentation also. They have done a CSF study, and tuberculosis workup was done, and it was completely ruled out prior to presentation. So now these are the possibilities, clinical possibilities, and we are proceeded with the following investigations. So the imaging showed, as you can see, this is a T2 flare, axial section showing diffuse involvement of bilateral white matter hyperintensities are there, slightly asymmetric, involving subcortical, deep white matter, and It is also involving the bilateral basal ganglia, left caudate is involved and bilateral lentiform is involved. Hyperintensities can be seen. And an additional finding in this image is that we can see hyperintensity involving bilateral substantia nigra. So a T1 contrast image is showing hyperintensities involving bilateral basal ganglia. And this flare section axial flower is showing hyperintensities in the bilateral basal ganglia. So with these imaging findings, our syndromic diagnosis remained the same. It was acute encephalitis syndrome. We were still thinking in terms of an infective, followed by an inflammatory, followed by a metabolic disorder. Now let's see what investigations revealed. So initial sepsis screen was negative. CSF cells were 10 lymphocytic and protein was 45 and sugars were normal. The workup for CSF workup for the common organisms like HSV, tuberculosis was all negative. Atypical workup was also negative, and retro and hepatitis markers were negative. We did a basic metabolic screening, glucose, electrolytes, lactate, ammonia, and ketones were normal. TMS, GCMS was negative, lactate CSF was normal. And in the autoimmune workup, the common antibodies were normal in the CSF and also in the serum. We had also sent a MOG and aquaporin antibody, and OCB also had been seen, which turned out to be negative. So with these investigations, the child was started on initial presentation. As I mentioned earlier, the child had fever, and after admission, the anti-seizure medications were titrated and no further seizures. And after antibiotics for 4 days, almost the fever subsided. There were no further fever spikes. There was persistent irritability. The child had to be started on nasogastric feeds, and there was paucity of movements on left half of the body. There was intermittent dystonic posturing in the child. Now, with these possibilities, our basic investigations as already ruled out common infective etiologies, and our basic metabolic screening was also negative. So since it is a treatable condition and the imaging findings were also suggestive, we had sent a demyelination panel, and we have got anti-aquaporin 4 antibodies strongly positive in this child. So we immediately started the child on immunotherapy. IVIG was given 2 grams per kg, and pulse steroids was also started, which was followed by oral steroids. We did have a dramatic recovery after initiation of the immunotherapy. First, in terms of the encephalopathy, the child started improving in terms of activity, play, there was improved interaction, and we were able to shift out of nasogastric feeds to oral feeds. There was even gradual regain of power of the trunk and on the left side of the body. And over a period of almost next 6 weeks, we noticed that the child started walking with support as well. The child was also started on azathioprine when the steroids were being tapered. So this is the examination finding of the child by around 12 weeks of follow. So now the child was more alert, playful, was interactive not only with the parents but also with us, responding to simple commands. The child was able to play a simple ball game. The cranial was very normal. There was hypertonia on the left side of the body. Power had improved, and there was no extrapyramidal signs. The best gross motor milestone attained by the child is that the child was able to walk with one hand held. The child was able to transfer objects. Immature pincer had appeared. The child was having stranger anxiety following one-step simple commands, and the child was able to vocalize but no clear words yet. So this is the video of the child in our last OPD visits. As you can see that he is attempting to walk with support as well. And this time he had become more comfortable with us. He was more interactive, and he has started using his left hand. This is almost after 12 weeks of immunotherapy. So we repeated the imaging at the end of 12 weeks. And on the left, what you see is the previous imaging baseline, and what on the right is the repeat imaging. So as you can see significantly on these player images, the hyperintensity in the basal ganglia significantly reduced as compared to the previous images. And also the white matter hyperintensities and the substantia nigra changes hyperintensity have come down. And again, white matter hyperintensities have significantly decreased with the recent imaging. And what you see now is more of a sequelae So at the end of 12 weeks, what we have is again a syndromic diagnosis of acute encephalitis syndrome. Now it has evolved as cerebral neuromyelitis optica spectrum disorder. So we have reviewed literature, and what is already known to all of us is the diagnostic criteria that has evolved over the years by Wingerchuk. In 2015, the breakthrough criteria came out, which says at least we need one core criteria among the 6, and which requires a positive serology of anti-aquaporin IgG antibodies with exclusion of alternate diagnosis to call it as a seropositive NMO spectrum disorder. Would like to highlight one more aspect of this investigation, where cell-based serum assays, especially microscopy or flow cytometry-based detection, is required because it has got sensitivity of over 76% and a very low false positivity rate of 1%. The indirect immunofluorescence assays and ELISAs have lower sensitivity, even that is in the range of 63 to 64%. So what we know is this, and what we have in our particular cases, among the core criteria, this child did not have a classical feature of optic neuritis, neither myelitis or an area posterior, which all these 3 are commonest presentations of an NMO spectrum disorder. We had involvement of the brainstem. We had symptomatic cerebral syndrome, but not very typical brain lesions, which are described in the aquaporin-rich receptor areas. We did have diencephalon involvement in the form of involvement of subthalamic nucleus with seropositivity, and we have excluded alternative diagnosis. So in the treatment aspects, what is well known is that there is a high rate of recurrence, almost like 50% at the end of 12 months after diagnosis. Proven therapies are rituximab. Upfront rituximab is being tried these days, which has come up with very low annual relapse rate. MMF, azathioprine, or practically feasible drugs, and even IVIG is being tried as 2 to 3 monthly basis, 1 gram per kg per dose is being tried. There are many other drugs like anti-CD20, anti-CD19, anti-interleukin-6 receptors are under trials. So what is atypical in our case is the age of presentation. The clinical presentation of an AE is turning out to be a different diagnosis, and imaging findings which are not very typical of an NMO spectrum disorder. So when we reviewed about the age of presentation, what is well known is, again, the commonest age group will be around 10 to 12 years, according to literature. And the youngest recorded patient in NMO is 16 months. And I think to the best of our knowledge, our patient presented at 11 months would be the youngest patient with a seropositive NMO spectrum disorder. This is a good article on non-opticospinal manifestations as initial symptoms. This is, of course, on predominantly on adults. So what is known as, again, vomiting, hiccups, vertigo, which is more like an area posterior symptoms, is quite common in adults and in pediatric age group when it is non-opticospinal. And again, meningitis or aseptic meningitis or meningoencephalitis can also be a presentation of NMO spectrum disorder, even as in our case. There has been case reports of just a presentation of an aseptic meningitis being NMO, turning out to be a NMO spectrum disorder. And again, there are literature because we were trying to find out why this child had a prolonged fever in the absence of inflammatory sepsis markers. So again, we came across some interesting case reports where prolonged hyperthermia has been a presentation along with other, of course, cognitive decline, hypersomnolence and all, because of the involvement of hypothalamus. And so this can be one of the important presentation of NMO spectrum disorder. So these are the atypicalities of clinical presentation that we came across. Now let's see what are the atypicalities in the imaging findings that we had in our case. What is classically known in NMO spectrum disorder is optic neuritis or a transspinal involvement, that is central spinal cord involvement. What we had in our case is a very striking basal ganglia lesion. So we were searching for lesions or presentations where basal ganglia can be a predominant. So there were a few case reports where basal ganglia has been involved, but these patients also had some involvement of spinal cord as well. Again, this is another case report which had diffuse involvement of cortical, subcortical along with basal ganglia. In fact, this was almost typical of a press Again, this was one case of NMO spectrum disorder with basal ganglia infarct in an adult female, and they had a tissue diagnosis, autopsy diagnosis of NMO spectrum disorder in this particular patient. And this is our own institute's publication. We had two different publications on the same. The initial images, just to highlight that you can have, this was a patient with NMO spectrum disorder, positive seropositivity was there. This is almost like similar with bilateral asymmetric white matter hyperintensities. On the left side, you can see that there was also basal ganglia involvement in our particular case. And also this is a child with OCB positivity. And there can be, the ultimate message what we are trying to say is that as the age comes down, the typicality of the presentation will vary. We do not have classical presentation of optic neuritis or myelitis in all cases of depression. What is this all about NMO spectrum disorder, or is there more to it? So as we were looking for more possibilities and etiologies related to this presentation, we came across something interesting related to mitochondrial dysfunction, which has been related to demyelination. There has been extensive case reports, but most of them are biological on animals and primitive human studies, which has been proven that mitochondrial genetic variations can influence the susceptibility to develop multiple sclerosis, NMO, and many other demyelination. It's playing a major role in demyelination disorder. So this is open for our investigations, and we are working on that basis as well. Thank you.
Yes, again, very good presentation indeed, Dr. Kaushik. Dr. Vishwaroop, can you just summarize or discuss this case?
Yeah, thank you, Kaushik. I think you stuck to time and you presented it quite well. So the main idea was that, when this child came to us, the child had already reached the nadir of illness within a week. And after that, whatever symptoms the child was having was primarily fluctuating symptoms. There was fluctuation in the altered sensorium. The child was having this fluctuating, movement disorder. The child also had seizures, which eventually got controlled. But what was the important clinical and I would say the clinical finding, which made a big impression on us, was the fact that the child was premorbidly absolutely fine. And then this child had developed a presentation in which there was an acute onset encephalopathy with fever. So when we got the imaging done, again, the differentials were quite wide, but we kept the possibility of an acquired demyelination syndrome. We thought it could be ADAM, but we sent all the markers primarily thinking that we had this previous experience where, as the age becomes more and as the age is less with younger children, you see more of overlap between genetic metabolic, infective, as well as acquired demyelination. So the same happened in this case as well. We sent the aquaporin 4 antibodies, they came strongly positive. And eventually now we are seeing that, the child has done quite well on immunotherapy. We don't give IVIG regularly, but the idea of giving IVIG in this case was particularly because this child had fever in the beginning. So when we had the aquaporin 4 reports, the child was still running low-grade fever, was recovering from that febrile part of the disease. And so we initially gave IVIG. Subsequently, when we ruled out all infective foci and the fever came down, we gave steroids, and post-steroids, which started the child on maintenance steroids, and now the child is on azathioprine. The other important fact, that we wanted to highlight is that the typical findings that we see with acquired demyelination, the diagnostic criteria that are there, these have been primarily validated mostly in adults, in the pediatric age group, more so in adolescents, and maybe in the latter half of first decade. The early presentations, that is the first 5 years of presentations, what we usually see clinically is ADAM, and radiologically also we see ADAM. But as we would go on doing, more of these immune markers in the serum as well as CSF, we would be able to understand these, entities better in the younger age group. So we did have brainstem lesions, but we didn't have lesions in area postrema. We didn't have periependymal lesions. We did have diffuse widespread white matter lesions, both in the subcortical white matter as well as periventricular white matter. But we didn't have those classical, patchy white matter lesions that are seen in the periventricular area, which are rich in, aquaporin 4 receptors in the brain. And so as it was seen that the optic nerves and the spinal cord were absolutely normal. So the message that we would like to give through this case is that if you have a child who is premorbidly normal coming to you with an encephalopathy kind of a presentation, acute to subacute onset, and in the right setting with clinical findings and some radiological findings, if you are finding a child of this, this phenotype, you should always think of treatable causes. And this was one of the reasons why we felt, that despite there was a lot of discussion amongst ourselves, we felt that most probably this is a metabolic cause that we are dealing with. Most probably this is a mitochondrial cytopathy. We still went ahead primarily because there was some asymmetry in involvement. Although it was diffuse, widespread, there was asymmetry in the white matter involvement. There was asymmetry even in the basal ganglia involvement. So we felt that we should definitely consider the acquired causes as well. The other important part, as Dr. Kaushik highlighted, is that many of these may have some mitochondrial influence. So that is one part on which we are working now. We would be most probably sending the genetic investigation for this child, planning next generation sequencing. We are talking to the family. And there were some cystic changes in the basal ganglia also to begin with, which are also persisting till now. So we don't know, there could be an underlying mitochondrial cytopathy, which made the child susceptible to this attack by anti-aquaporin 4 antibody, which was also highlighted by Kaushik in the concluding slides. So that's it from our side. Comments from Shifali ma'am. So ma'am is already there. Ma'am,
Shifali ma'am, if you can speak.
Yeah. No, very nicely presented. 2-3 take-home messages which I may reiterate from what Vishwaroop has said. Firstly, that we have to keep in mind that acute encephalitic syndrome may have a lot of causes, and we have to keep an open mind, and especially for the treatable causes, as very rightly pointed out by Vishwaroop, and it is always wise, to rule out, have a high index of suspicion and rule out the treatable ones. Like whenever we having fever in the beginning, we obviously end up giving IVIG to them, and it is then we wait till you give steroids. Other thing is, there is a host factor is very important. We we have to keeping in mind whether you're talking about any conditions, whether it's a variant manifestation, neurotuberculosis or anything. So we do not know. So all of these genetic things can be there. If you're finding one thing, doesn't mean that you don't look out for the others. And as pointed out, that younger children will obviously, you'll have to think they may have be a lot of atypicalities. And as Kaushik had reviewed that there was some mitochondrial dysfunction and all has been reported with MS. I wanted to just mention, although not related to the case, that there have been many studies in which ketogenic diet therapies are being tried in multiple sclerosis and many refractory demyelination. So in that, you can keep in mind in your future practice, if you get stuck anywhere, that you can just try ketogenic diet therapies. Thank you. I think very nicely presented, Kaushik, and nicely mentored, Vishnu. Thanks, Gurpreet.
Thank you, ma'am, for commenting. So there's one question that as these lesions are not typical, could this aquaporin 4 be just an epiphenomenon? Vishnu, would you like to comment?
Kaushik, would you like to comment?
Yes, sir, we have done a cell-based assay for aquaporin 4. And so false positivity is very, very low. So that's something that we had extensively reviewed in this thing. Second point is that it is the dramatic clinical response that we saw in this particular case. We were pretty sure that we did have possibility of a metabolic disorder or an infective etiology initially. So we are still working on it. We would definitely be sending a genetic investigation, sir. But as of now, the way the child has clinically responded, the way the imaging radiological response has been there, and with the cell-based assay, we are quite confident that it would be in a more spectrum result. Yet we are open for the possibilities.
Is there Dr. Sarvesh there? Can you comment on imaging findings? Have you seen such findings previously with NMOSD or Dr. Sarvesh?
Sir, yes, sir. Yes, sir. I'm available, sir. Yeah. Sir, we have seen asymmetric involvement of basal ganglia. And in fact, yesterday only I reported a case with necrosis of globus pallidus, which I was not trying to believe. I mean, that's an adult. I was not believing it's because of NMOSD, but it did come proven as NMOSD, and the patient has improved post-treatment. So yes, sir. And large hemispheric lesions along with basal ganglia involvement. If we see large hemispheric lesions, they are also a feature of NMOSD, like we had in this case, the frontal one, which led to gliosis in the follow-up.
Yeah, Gurpreet sir, I would just like to add, what was important is this was a cell-based assay, and the report that came to us was strongly positive. So usually when we get a report, it is positive, either for MOG or aquaporin 4. So the word strongly positive further reiterated the fact that even the microbiologists and the immunologists were quite sure that aquaporin 4 positivity was there. The other thing is, as rightly pointed out, it can definitely be an epiphenomenon, and that is where the role of mitochondrial inheritance and mitochondrial influence on manifestation of these immune mediated disorders come, and so that is why we would be investigating it. It definitely doesn't look like a coincidence, but yes, there could be another underlying factor which could have precipitated this NMOSD-like presentation in this child, and which we'll be working out.
So do you give upfront rituximab in these cases, or?
So what we usually follow is that we would start with pulse steroid unless and until there is a contraindication to steroid, say in the setting of an infection. We would start with IVIG. We would give pulse steroid. Post pulse steroid, we would give 2 weeks of oral steroid. So we usually give this duration of 2 weeks to see how much the child is responding. If there is a good clinical response happening, then we wait. If on 2 weeks follow-up, the clinical response is not that great, then we definitely consider rituximab, at that point of time during the acute attack. What we do in follow-up is that suppose we are dealing with a case of multiple sclerosis or a case of NMOSD where long-term immunomodulation is on. If on these long-term immunomodulators, the child has a relapse, so the first thing we do is we treat with rituximab, and then, either we go up with the dose of long-term immunomodulation or we change the long-term immunomodulator. So we use rituximab in both ways, steroid refractory acute attack, and on long-term immunomodulation, if there is a relapse, we are using rituximab. So these are the 2 scenarios in which we are using.
So thank you, everyone. And just one more query, that the images you showed at the last of the case, that there are a lot of sequelae in this case. The last image, if you can share again, Dr. Kaushik. The frontal lobe gliosis was there. The same case, right? The images were of the same case.
Yeah, Kaushik, can you just bring that? In fact, I want to. Yeah. So if Kaushik just So if you see, Gurpreet, if you see, look at these areas. So these were the subcortical gray matters. So if you see this subcortical gray matters, these things have come down. What you can see, even the lesions here, these have come down. He's still 13 to 14 months. We can still have unmyelinated white matter. The insult on myelin could have also led to some delayed myelination, otherwise that is going on. So the sequelae, I think, would be actually able to comment more at an image set around 18 to 24 months of age, because the myelination process is still on. So we have even kept that part also in mind, that the normal process of myelination could also get a bit delayed because of the insult that has happened, this early insult. Because most of these areas, if you see, can be seen in normal children also as unmyelinated white matter, even at 2 years, 2.5 years, 3 years. So this is one of the reasons that we would also like to radiologically follow this child over next 6 months to 1 year.
Dr. Lokesh wants to say something.
Yes, sir. Sir, I just remembered a very interesting case similar to these lines. So recently seen around 6 months back, child presented with acute onset encephalopathy post viral prodrome, was COVID antibody was positive, had a leukodystrophy kind of pattern in MRI. So we suspected leukodystrophic pattern of MOG, and we've sent the panel to NIMHANS. We usually send to NIMHANS, and it has come strongly positive. We treated the child has improved, again came back after 6 months with a relapse, again had that similar kind of pattern, and again antibodies were positive. But this time Dr. Sarvesh suggested that I am suspecting something more, and we should work up for the genetic part. So he's thought of possibility of Alexander disease because of leukodystrophy pattern, frontal predominant leukodystrophy, symmetric changes. Those were there, they have subsided to an extent, but again reoccurred. So we have sent genetics for this child, and it has come strongly positive. It has come positive. So pathogenic variant was there, and now the child is progressing. We have again repeated MRI. Now the child is progressing, like the typical MRI changes of Alexander's are there. So
MOG was false positive, or
the MOG was so there were reports in literature. The MOG can be, the GFAP was positive for Alexander, and MOG is a no, like there has been co-reports. So we have discussing that NMO can be associated with this mitochondrial kind of thing. So again, the similar kind of dual pathology.
Yeah, so just to add to what Lokesh said, sir, so we have in fact anti-GFAP antibodies also are being evaluated these days in acute demyelination. So a lot of these places in which are seronegative for aquaporin 4 for MOG, they are being evaluated for anti-GFAP antibody, which is actually the cause, the mutated protein in Alexander. So you can definitely have an overlap where there is an autoimmune insult, and then you actually have an underlying mutation which makes them more susceptible. So a very well point taken.
Dr. Kavita has also shared that NMOSD as a stroke mimic also can be there. And they have a similar case in older child, and her second episode was area posterior syndrome. So the relapses can be typical. The initial presentation can be atypical. So I think thank you very much. Very nice, excellent cases. Thank you, presenters both, and the moderators, the chairpersons. Thank you all for chipping in and sharing the wisdom. So I thanks again, and I think we'll stop here. Thank you.
Thank you. Thank you, sir.
Thank you, sir.